Good afternoon, everyone. Thank you so much for joining. My name is Jordan Fallon, and I will be the host of today's Solventum Afternoon Coffee. I am joined today by two of my wonderful colleagues. One of them is Nichole Soderquist. She is a Solventum consulting manager, and also joined by Sue Belley, who's also a Solventum consulting manager as well. So today we'll be diving into some of our consulting services for our small community hospitals. We appreciate all of you joining us today and giving us some time. Before I pass it over to Sue and Nichole, I want to just go over a few housekeeping items. First is we'll be having a poll question or two throughout the series, so please feel free to engage with those. We'd love your participation. With respect to time, we are going to give a few moments to participate within the poll, but we will move on with the presentation. The poll will stay live for you to engage with after the fact. We also want this to be a collaborative session, so if there are questions during, please feel free to put them in the chat or the Q&A portion of your toolbar up at the top. And lastly, the session will be recorded, so we will be distributing that after the fact. So again, we appreciate you taking some time to be with us today. And Nichole and Sue, I will turn the floor over to you.
Okay. Thank you for joining Nichole and me this afternoon to talk about one of the consulting service lines we work in with our customers. We'll explore opportunities within the outpatient revenue cycle, which is a critical area for enhancing healthcare efficiency and profitability. This session is part of the Afternoon Coffee Series, and we appreciate your participation with us today. As we delve into this topic, consider how optimizing the outpatient revenue cycle can lead to greater compliance for your organization, accuracy, and improved financial outcomes. So we're going to start out with a poll question. We'd like to know what your current role is in relation to the outpatient revenue cycle in your organization. So please take a minute to answer that. Okay. So when we talk about the outpatient revenue cycle, in my opinion, it's extremely complex, perhaps much more so than the inpatient revenue cycle. And, I've definitely worked in both cycles in my long career in coding, documentation, and health information management. So why is it seemingly more complex? First, just the sheer number or variety of types of outpatient encounters: PD, ambulatory surgery, interventional radiology, ancillary visits, wound clinic. The larger the organization, the more outpatient departments there are. And each of these different areas in outpatient revenue cycle to have their own coding and billing requirements for the various types of encounters, which makes it difficult to manage and be aware of all of those things. I say that, many different hands influence and touch the revenue cycle before the coding process and after the coding process occurs, as the encounter initiates and the claim moves down the pathway to final billing. We also have frequent billing and coding updates and changes that occur in the outpatient revenue cycle. I think during the public health emergency for COVID-19, that was especially evident. We were getting new CPT codes and HCPCS codes for the various COVID vaccines that came out, sometimes on a monthly basis, different guidelines to follow with regard to telehealth and things like that. So, these factors, along with many other, make it really difficult for organizations to keep their eyes on all the moving parts of the revenue cycle and make sure that they are functioning properly. So, when we talk about outpatient revenue cycle challenges, I've listed, some of the typical challenges, and believe me, there are so many more, as I'm sure you're aware. When we think about our observation patients, we often have conflicting orders. Are they being admitted as an inpatient? Are they going home? They're coming from the ED to observation. So putting your finger on what is the status and is the order correct, it can be difficult and cause problems in the revenue cycle. We see, opportunities, for example, in infusion injection. It's frequently a problem to, have good documentation that supports start and stop times, and for coders to correctly assign codes for various infusions and medications that are injected into patients. We see medical necessity edits bypassed throughout the system, leading to opportunities. So, whole host of outpatient revenue cycle challenges. And due to time today, we won't talk about any of them in depth, but just an illustration of the complexity. We're going to take a minute and ask a second poll question. How does your organization try to maintain accuracy and compliance within the revenue cycle? So please take a moment and select the response that you're aware of or best fits your facility. Okay. So, one of the things that we've done at Solventum is to help our customers put together an outpatient scorecard. So, what we do is we look at 4 different metrics that we can obtain information on from the CMS's publicly available MedPAR data file. I'm sure you're aware that the MedPAR file is, published and kind of runs behind it. Right now, we have 2023 data available. It just takes the government a long time to be able to, analyze all the claims that come in from across the country and put all the data together. So we have, 4 metrics that we'll talk about. I'm going to turn this over to Nichole so she can dive into more detail about that. Nichole?
Thanks, Sue. So as Sue said, our scorecard, outpatient scorecard that can assist your facility in identifying opportunities. We will be discussing each 4 of those metrics. When we look at these, we identify trends, we uncover opportunities for improvement, and ultimately we do try to provide those quick wins, driving that financial outcome in a better place for you. So the first metric that we discuss is the emergency department level distribution. And this is crucial for understanding how facilities, they classify their patient encounters. So what CMS has done is they've allowed a lot of flexibility surrounding evaluation and management leveling on the facility side. So it's important that we do benchmark against the state's distributions and not just look at your organization itself. So CMS, they let us each decide how we want to set our evaluation and management levels to match certain resources that we're providing within our emergency department and what we're doing to treat those patients. There are 11 guiding principles that CMS does require facilities to follow when they do create their evaluation and management leveling method. So within our scorecard, we do a comparison using that MedPAR data that Sue just discussed and compare your facility level to the state level. What we are looking at is the bell curve. Are you higher in one level than another as far as the state? And some of the trends, if you see more critical patients, you may be a higher level 4 than what the state is. It all depends on the demographic of the patients that you are seeing. But what we really want to do is avoid those downgrades. We want to ensure that you are accounting for all of the resources that you are providing within your emergency department. And if you do have a calculator that's being utilized, it's calculating correctly. So questions that we commonly ask our customers is, when was the last time the facility's leveling criteria was reviewed? Are you picking up all of the nursing interventions that can contribute to that E&M level? If the facility is using an EHR calculator, again, when was that updated? Checked for accuracy? Because there are times where these items, even though they're in the EHR and we're depending on them, they do break. Are you receiving any payer downgrades for levels 4 and 5? We hear about that quite a bit, where the levels are being downgraded, but we really don't know unless we go back and look, because the insurance carriers are not necessarily telling the organizations they're downgrading. They're just downgrading on that reimbursement. And then if is any part of the emergency department revenue cycle being affected in any other way? Like Sue mentioned before, medical necessity. Are you receiving those medical necessity denials? So that is one metric that we look at and we analyze to help show some type of opportunity. Because again, 2 years, the data is 2 years old, but if no changes have been made since that time, there's probably still opportunity there. So going into the next metric that we look at on the outpatient scorecard, this is the inpatient only procedures that are performed in the outpatient setting. And this can lead to a significant revenue loss. Now, Medicare does not reimburse for any of the services where an inpatient service was performed in that outpatient setting. And this component of the scorecard, it highlights the importance of identifying such occurrences quickly to mitigate financial impact. So understanding the reasons behind these misclassifications, it can help refine processes and improve compliance with CMS regulations. Maybe there's a process broken with your scheduling where the CPT code that is being used at scheduling is checked against to see if it's an inpatient only procedure and the wrong CPT code is used. Or is it on the back end where maybe coding is not accurately coding the case and it's getting labeled as an inpatient only code, but in all reality, it still qualifies as an outpatient procedure because the wrong code was assigned. So if there's a lower number of cases on the scorecard, we don't want to turn away from that. So we would still feel like it's worthwhile to review and see if any opportunities for improvement can be identified for any organization. And then when there is that significantly high number, like we have here as an example, that $1 million over 15 claims, that's a huge loss. And if you haven't changed any practices in the last 2 years, add that up, you're almost at $3 million loss if you go 23, 2024 and 2025. So again, now just think about, where you're at currently in your small community hospital and improvements that could be made here. And I'm going to discuss what we can do to help you coming up. But going into the third metric, are observation claims over 48 hours. So CMS's policy on observation claims exceeding 48 hours, it presents challenges for all facilities because these services are not reimbursed after 48 hours. So here we do outline some common issues that can arise, such as incorrect physician orders or placing the patient in the wrong status, coding problems. This could include carving out hours, observation hours, because every time that patient leaves that observation floor for a service and a nurse doesn't go with them, they're no longer being observed. So we have to carve out that time from the time they're gone to the time that they come back. Appropriate assignment of condition code 44 is another issue that we see when it comes to observation services. So addressing these challenges, it is vital for optimizing any observation services and ensuring that you do capture all potential revenue. So in the cases here, where we would populate in the scorecard. If it is either high or low, they're equally important because we do not know by looking at the impacted claims how many specific hours are over 48, but it does give us an idea of where you're sitting. Because sometimes, even a patient, they may be here an extra day or maybe 3 days. Regardless, it is just labeled as a claim over 48 hours. So it could be multiple hours you could be losing out on. And again, any number here identifies opportunities to reduce revenue leakage. And our fourth metric is our potentially preventable medical necessity losses. This is the use of the GZ modifier. So this is a critical aspect of managing those potentially preventable medical necessity losses. So this metric provides us with how facilities can self-deny services that do not meet medical necessity requirements. So we analyze the frequency of how often these modifiers are appended to services, and we can identify the areas of opportunity. So as I mentioned with observation, high or low is an opportunity. And that is the same here too, because if we have a low volume where GZ modifiers are populating on our scorecard, this could possibly mean that you still have a lot of revenue leakage. Your organization just is not tracking or self-denying with Medicare and appending those GZ modifiers. Whereas in the case that we have on the screen here with the impacted line items and potential revenue loss, this fictitious organization, they have a $2 million loss because they are appending those GZ modifiers. So these are just opportunities that we want to help organizations with, identify, fix processes, and, obtain those quick wins. So we have one more poll question, and this is in regards to the GZ modifier. So does your organization currently apply the GZ modifier? And again, the GZ modifier is indicating that a service is expected to be denied by Medicare is not reasonable or necessary. So if you could answer that yes or no, it just helps us understand the landscape of how GZ modifier usage is different across organizations. And then we will move into our Solventum solution. So this is how our services can address the challenges that are faced in the outpatient revenue cycle. So we focus on tailored solutions. We aim to enhance that operational efficiency, as Sue mentioned earlier, that financial performance as well. So this, once we run your scorecard, this is when we then would transition into that Solventum solution. So our Solventum approach comes in 4 phases, and the first 2 phases, they go hand in hand. So the analysis and the assessment. So what happens here is with our approach, we would take in 2 years worth of your claims data, and this is typically 2 calendar years of claims data. And we would analyze it within our tool. And currently we have 153 facility KPIs. And I know we're focusing on the outpatient facility in our coffee talk today, but we do have KPIs set if you employ your physicians as well. So there's 120 professional KPIs that we could run your 837Ps against to also provide you with some key performance indicators. So once we run that 2 years worth of claims data, we will analyze it against those KPIs, identify trends, identify opportunities, and report back to you what our findings are. And then we would make a recommendation based on the top 3 findings of where we would like to look further into. And then this leads into that assessment phase, where we would take the claims data that we chose to take a deeper dive in, such as, say, your interventional radiology, your GZ modifiers, or maybe your diagnoses. And we would pretty much basically look at the documentation to see if everything was coded correctly, if the documentation was correct. maybe there was medical necessity loss and it was coded as a medical necessity loss, but that documentation actually showed that there was a diagnosis to cover the medical necessity. And this is where we uncover those parts. And then the third phase is the implementation. After we uncover your opportunities, we do a performance improvement implementation, helping you come up with a plan to improve processes. If you're looking at outpatient CDI program, we help stand those up as well. And then upon completion of that implementation, we move into ongoing support, where we would continue to take in that claims data quarterly or semi-annually. Or even biannually, to continue to see if more areas. So let's say that we didn't find an opportunity with colonoscopies the first time around, but now that you're continuing to send us data and it's more current, we're seeing an opportunity. So if something is broken, we would recognize that and report that back to you as well. So those are the 4 phases to our approach when using our Solventum tool. Now I'm going to pass it back to Sue, and she will discuss the benefits and outcomes of it.
So we really, like our approach and feel that it works really good for customers, because if we can surface opportunities for customers in the outpatient revenue cycle, they can be, fixed fairly quickly and can lead to quick financial improvements. We can, identify revenue cycle opportunities for the facility outpatient departments. And as Nichole mentioned, if you employ your physicians, and we look at your professional data, we can help in that arena as well. We can, help decrease revenue leakage and improve the capture of revenue all around. And, it can help organizations keep abreast of these ongoing opportunities that, with all the changes that happen. And like I say, the revenue cycle breaks every day. You hire someone new in inpatient registration and they classify patients incorrectly, or you have a biller on the back end who is getting an edit when they're trying to get that claim out the door, and they remove the modifier because it clears the edit. That may cause a huge problem. So, to keep on top of all these opportunities and things that go wrong, our team can help organizations with that. Tracking progress on improvements. If you were having a problem with inpatient only procedures, constantly monitoring and making sure everything stays fixed, you can show that you're making an improvement to your leadership. It helps provide opportunities to resubmit correct claims if we find something that's inaccurate for your organization, and helps maintain compliance and ensure accurate reimbursement, be it underpay or overpay, and can help reduce all the denials and rework. If you ever look at an 835 file and you see how many times claims are rebilled, there's statistics out there in the world that equate how much time is spent in reworks and how much that costs organizations. Another benefit is to, improve, performance and knowledge for the revenue cycle staff and providers as well, with regard to, documentation opportunities and, making sure that they document medical necessity diagnoses if, those are missing. Um, helps improve overall clinical documentation and, the coding that goes along with that. So lots of benefits and outcomes, but I like to say, these can be very quick wins. So, I think from, talking with customers over time, we hear a lot of customers say that they don't focus as often on the outpatient revenue cycle as they do on the inpatient revenue cycle, because inpatient revenue cycle has bigger dollars. But, we counter and say, you know, if you have a lot of medical necessity issues, the $1 million in GZ modifiers, that's a lot of money. It's a lot of cases with smaller amounts of dollars that can really add up. And in some cases, not smaller dollars when you think of, medical necessity needed for CT scans and MRIs of the head, that can quickly add up. So, that's where we're at with, benefits and outcomes. So, that those are some of the things that we wanted to, talk to you about today, while you're sipping on your coffee or your afternoon tea. As Nichole talked about our scorecard, if you're interested in having us run a scorecard to look at, just these 4 metrics that we can get from, CMS, we're happy to, do that for you, and then, schedule a call with you and us and your salesperson to, kind of give you a quick analysis of what we see on that scorecard, and talk about how we might help you in other areas of your outpatient revenue cycle. So, so I don't know if we had
Wonderful.
some questions come in that we might ask or answer, I should say.
Yep, we have one that's in the chat. My
Okay.
organization does not seem to have the appetite for addressing the outpatient revenue cycle due to small dollars. How can I get their attention? You want me to answer, or do you want to?
Take it away.
Okay, numbers. Show them numbers. Administration likes the numbers, even if it's not completely financial, they like numbers. So as Sue mentioned, outpatient, it is a lot of encounters and the dollars are small, but the dollars, they add up. So if it's not medical necessity, think back to those inpatient only examples that I showed on the scorecard. 15 inpatient encounters, and that equaled over $1 million. So if you know of an area where you see opportunity, start gathering your data to show numbers where there is opportunity. And that is the best route to go, is collect your data to take to your administration to show them how much it's adding up to. And then if it's a compliance issue too, you could also include that in your reasoning. Sue, anything else?
Yeah, I think we worked with a customer recently that had inpatient only opportunities. And as we delved into the cases to figure out, how did they land up in the inpatient only status, we found, 7, 8, 9 cases of women who underwent hysterectomy. And I'll say they underwent the garden variety laparoscopic hysterectomies. And when we reviewed the operative reports and we looked at how the procedures were coded, they were coded to the CPT code for a radical hysterectomy. However, the documentation of what actually occurred in the OR did not support radical hysterectomy. And the CPT code for the radical hysterectomy made it an inpatient only procedure. So it was to the tune of a couple $1 million. And, as HIM coding professionals, Nichole and I were like sick for the organization, for the coders that assigned that code incorrectly. And, that's a knowledge deficit to, assume the garden variety hysterectomy as a radical hysterectomy and assign the wrong code. The organization didn't get paid for one bit of the case. It's not just the procedure, it's the whole ball of wax doesn't get paid for. So, education was able to be done for those coders, a plan put in place to look at any, inpatient-only procedures before they went out the door, to see if they were truly inpatient-only procedures or, something else was wrong, like incorrect coding. So, it's
Yep.
a quick fix too.
And that's where training comes in. We do have one more question. Is there a cost associated with obtaining the scorecard? No, there is no cost associated. There's no contracts. All you're doing is requesting the scorecard, and we will follow up with you as far as the results of it. It is free.
Wonderful. Nichole, Sue, this presentation has been extremely valuable and lots of good insights. We are at time for today's session, so we do appreciate everyone joining us today. The recording will be followed up after today's session, so please do look for that. If there are any requests for any more information, please feel free to use the QR code or we will reach out with additional information. We appreciate you joining and we look forward to seeing you on the next afternoon coffee. Nichole, Sue, thank you so much again.
Thank you.
Everyone. Bye-bye.
Everybody have a great afternoon.